All right, so good afternoon, everyone. My name is Paul Mangine. Today I would like to discuss my thesis topic, implementation of priming additives in cardiopulmonary bypass circuits with a focus on renal functionality and coagulation status. I have no disclosures at this time. So this clinical investigation comparatively analyzed the priming methodologies of two different institutions and their effects on patients receiving cardiopulmonary bypass. This was done by evaluating pre- and post-operative kidney function and coagulation status over the course of 24 hours. Two different priming methodologies at separate institutions were investigated. One institution primed their circuits with strictly crystalloid solution. This will serve as our control, while the second institution in question primed their circuits with not only crystalloid, but with the addition of albumin and mannitol additives. And this will serve as the study's treatment group. This study will focus on patient outcomes in regards to renal function and coagulation status. During this investigation, data was acquired at 3-time intervals, pre-bypass, immediately post-bypass, and 24 hours post-bypass. So currently there is no standardization or optimal method unanimously agreed upon by institutions performing cardiac surgery regarding the contents of priming solutions for cardiopulmonary bypass circuits. And crystalloid solutions are pretty much used to mitigate the exacerbation of acid and base and electrolyte abnormalities. Specifically, they can be referred to as physiologically balanced solutions. Opponents to this methodology argue that using crystalloid prime alone is unable to protect against platelet activation and consumption. Not to mention, this can cause negative outcomes associated with hemodilution, such as postoperative edema in multiple organ systems and postoperative renal deficiencies, potentially leading to acute kidney injury. So despite interventions made by institutions to decrease priming volumes and shorten their circuits, some feel additives to the primer still required. I would like to take the time to briefly review the additives in question in this study. First, we have albumin. This is a natural colloid or globular protein found in our plasma that exerts an osmotic pressure. The main advantage offered by albumin for priming is represented by acting as a natural coating to the circuit and oxygenator. This prevents fibrinogen absorption and platelet adhesion to the surface of our circuits. This lowers the chance of platelet activation, oxygenated thrombosis, early thrombocytopenia, and lowers an incidence of microthrombosis leading to impaired organ perfusion. A meta-analysis was performed in 2004 to determine the effect of pump priming with albumin. Evidence from 21 controlled trials found that albumin exerts significant favorable effects on patient outcomes regarding platelet counts, oncotic pressure, and postoperative weight gain. So mannitol is an osmotic diuretic. It does not undergo tubular reabsorption within the nephron. Thereby, it increases the intratubular osmotic pressure and inherently increases urine output. Although a multitude of studies in both human and animal models continue to report conflicting data regarding this justification of mannitol, it is still frequently administered within the perioperative setting. Studies in the past have claimed that mannitol-treated patients display increased diuresis, suggesting improved renal function post-surgery. Although the maintenance of urine output during bypass is desirable in order to diminish the fluid overload, no other studies have been able to confirm mannitol as a renal protectant. A thorough systematic review was recently performed substantiating the shortcomings of mannitol as a perioperative renal protectant, citing a lack of evidence in mitigating the effects of postoperative acute kidney injury. So a few studies compare the effects of crystalloid prime with pairing of both albumin and mannitol in tandem. There's been one prior investigation grouping the additives of both mannitol and albumin with a focus on bleeding and coagulation status. This was a randomized single-center controlled study consisting of 134 patients. Bleeding volume, transfusions, fluid balance, coagulation parameters, they were all determined over the course of 48 hours. Both patient blood loss and length of hospital stay fell in the treatment group, but these results were not significant. Intraoperative and postoperative fluid balances were significantly less positive in the treatment group. And I would also like to note that this investigation failed to investigate the effects in tandem regarding kidney function. So that leads to the purpose of this investigation, which was to compare priming methodologies of two clinical institutions in order to evaluate the superiority of albumin and mannitol additives in regards to kidney function and coagulation status. Therefore, my hypothesis is that albumin implementation in the treatment group will exhibit a lower incidence of platelet loss, leading to decreased amounts of postoperative bleeding. In addition, the treatment group receiving the mannitol additive will display higher levels of kidney function in regards to lower creatinine, increased estimated glomerular filtration rates, and higher urine outputs when compared to the control group. So 20 subjects were selected at each of my institutions I visited. The first institution would be viewed as the control group, or group C, and all patients here undergone bypass with strictly crystalloid-based primes. The second institution would be considered the treatment group, group T. All patients in this group had undergone bypass with circuits primed with mannitol and albumin additives, along with crystalloid-based primes. Both groups undergone bypass utilizing the same equipment with the application of similar perfusion practices. So in regards to renal function, values of interest in this study were creatinine levels, estimated glomerular filtration rate, and urine output. Urine output was measured during the bypass, and it was measured in the ICU setting 24 hours after surgery. Coagulation function was evaluated with platelet counts and chest tube drainage. The chest tube drainage here was measured in the ICU setting 24 hours after surgery. So patients were selected by considering exclusion and inclusion criteria, then divided into control and treatment groups based on each institution. Subjects with normal kidney physiology were scheduled to undergo elective cardiac surgeries between June and October of 2019. Patients were excluded due to emergency surgery and previous histories of the following: any prior cardiac surgeries, antiplatelet medications besides aspirin, preoperative coagulation disorders, preoperative renal dysfunction, especially if anyone had a creatinine greater than 1.4, excessive utilization of hemoconcentration on bypass, and LVAD or intra-aortic balloon pump dependencies. Data was described in terms of mean standard deviation. Intragroup comparisons of variables were performed using a paired sample t-test in order to assess pre- and post-operative changes within both the control and treatment groups, as well as a repeated measures ANOVA was run to interpret intergroup comparisons between treatment and control groups. So really quick, the experimental design. Preoperatively, the patient's baseline renal function and platelet count was assessed based on pre-surgical lab values from blood samples taken within 24 hours prior to surgery and documented via electronic medical review. The patient would then undergo a cardiopulmonary bypass, and then post-operative data was collected during 2 time periods, when the patient first entered the ICU setting and 24 hours after surgery. So let's get into the data. First, we have an intragroup comparison of variables that was performed using a paired sample t-test in order to assess the pre- and post-operative changes within the control and treatment groups. We're looking at creatinine here. I would like for you to direct your attention to the difference in the pre- and 24-hour post-operative time periods. These are the first and third bars for both patient groups. The mean creatinine value of the control group on the left in lavender showed a significant decrease of 7.4% between the preoperative and 24-hour post-operative time intervals. If we look at the treatment group in green, although it displayed a similar rate of decrease, the mean average for creatinine was less when compared to the control group during the same time interval of pre to 24-hour post. Yet this data was not deemed significant for the treatment group. And for future reference during this presentation, just keep in mind, both the treatment and control groups are plotted together for perspective purposes. They cannot be compared from a statistical standpoint, as the paired samples t-test does not have that capability. A repeated measures ANOVA was run to interpret intragroup comparisons between treatment and control, but unfortunately, in regards to creatinine, they were not significantly statistically, show no significant statistical relationship. So estimated glomerular filtration. This was calculated from serum creatinine levels, and we used an isotope dilution mass spectrometry traceable equation from the MDRD study, also known as the modification of diet and renal disease. This was acquired from the National Institute of Diabetes, Digestive, and Kidney Disease. This is a widely used traceable equation for estimating glomerular filtration rates in patients ages 18 and over. The equation utilizes variables such as age, gender, and race, and can allow providers to observe, which may allow providers to observe that chronic kidney disease is present despite a serum creatinine concentration that appears to fall within normal reference intervals. So if you look at the treatment group in green, there was a significant 9% mean increase during the pre to 24-hour post-operative time interval. This was deemed higher than the 5.7 increase in the control group, although the control group during the same time interval was not deemed significant. We ran another repeated measures ANOVA on this intergroup comparison and unfortunately showed no significant statistical relationship between control and treatment in regards to estimated glomerular filtration rate. So as far as urine output is concerned, although the treatment group excreted more urine during perioperative and postoperative periods compared to the control group, the urine output increased in the control group at a higher rate, believe it or not, 589% compared to the increase of 446% in the treatment group during the same time period. A repeated measures ANOVA was run to interpret intergroup comparisons here and was actually found to be statistically significant. And we're going to look at these results right here. And here we can see the treatment group displayed a significant 74.3% increase in urine output during the bypass run in comparison to the control. Meanwhile, patients receiving additives in the treatment group secreted 138% more urine over the course of a 24-hour postoperative period when compared to control. And finally, we have platelets. Once again, I would like for you to focus your attention to the differences in pre versus 24-hour post time periods. The control group displayed a significant 33.2% decrease in mean platelet levels during the pre to 24-hour postoperative time interval. Within the treatment group during the same respective time interval, we observe a significantly lower drop in platelet loss at 27.9%. A repeated measures ANOVA was run here and unfortunately showed no statistical relationship. But please do notice a trend of overall decrease in platelet loss within the pre and 24-hour postoperative periods within the two groups. Platelet counts did fall by 33.2% in the control, and only a 27.9% reduction was observed in the treatment group. Although we just observed a trend of decreased platelet loss in the treatment group, this did not correspond with lower incidence of bleeding via chest tube drainage. Here we can see the treatment group in green displaying slightly higher levels of chest tube drainage. A repeated measures ANOVA was run here to interpret intergroup comparisons, but unfortunately there was no statistical significant relationship. Therefore, my hypothesis cannot be supported due to lack of statistically significant evidence. I would like to point out that the treatment group displayed interesting trends of lower average creatinine values, increased rates of estimated glomerular filtration, and decreased levels of platelet loss after the 24-hour postoperative time interval in comparison to the control group. But unfortunately, like I said, these observations were not statistically significant during the intergroup analysis. Additionally, mitigating platelet loss did not significantly correlate with a decreased incidence of bleeding. Considering the control group displayed slightly lower volumes of chest tube drainage compared to the treatment group, this could be attributed to differences in maybe surgical technique among a multitude of other coagulation variables that we did not account for in this investigation. Therefore, these results are not able to indicate support for albumin and the prevention of platelet adhesion to circuit components. To consider the addition of albumin to priming volume in bypass circuits as a deterrent for postoperative bleeding could be seen as an overstatement. Intraoperative and postoperative urine output was significantly increased in the treatment group, which demonstrates reasonable association amongst priming additives and their ability to decrease clinical symptoms of edema secondary to volume overload during the 24-hour period of cardiopulmonary bypass. But this cannot be proven to have an effect on kidney function or attribute to reduction in kidney injury. So given the time constraints and lack of resources, this investigation was unable to accumulate an appropriate sample size. This inherently dampens any statistical efforts attempted or achieved during this analysis. Note that each bypass run was not standardized with the same surgeon or perfusionist. This allowed for implementation of various philosophies regarding patient care to be applied. Although popular, serum creatinine is just as unreliable as it is delayed, making it hard to account for short-term changes in kidney function. Kidney injury biomarkers such as NGAL and cystatin C could hold potential for examining glomerular filtration rates, but both have been reported to provide an earlier and better predictive value for kidney function, yet further research is still required. I'd really like to throw out a special thanks to my program director, Dr. Michael Smith, Professor Brian Schwartz, and all the dedicated preceptors I've had over the past year. And thank you so much to Perfusion.com. I'm very grateful for this opportunity to present. And here are some references. And thank you. I'll take some questions.